me well? Good afternoon. I am Radhika Mazumdar. I am a pediatric endocrinologist. I practice at Children's Hospital at Montefiore. And the title of my talk today is Growth and Development. So when you think of growth and development, there are two broad stages of growth. One is, of course, the fetal growth. Here in this talk, I'll briefly review fetal growth and talk about endocrine factors that regulate fetal growth, but most of that will be covered in other sessions. Majority of the focus will be on postnatal growth, that is growth after birth till we finish growing. So when you look at fetal growth, it's incredibly complex. Starts from a single cell, and we end up with 200 different cell types. And from beginning to end, the length increases 5,000-fold, and the weight increases some 6 times 10 raised to 12-fold. It all starts with a basic genetic plan, that is our chromosomes and genetics, and with adequate oxygen and nutrients and a few growth factors thrown into the mix, is this phenomenal growth we observe from a single cell to 200 different cell types. So when you think of the factors that influence fetal growth, it's fairly simple. It depends on the environmental factors. We can see why maternal size and maternal nutrition would affect fetal growth. And this has been clearly demonstrated in conditions when there's famine, during wars. When the mother's nutrition was not adequate, the babies were born smaller in size. This is true for developing countries, and I think this relationship is quite well established. Not only maternal nutrition, placental function is an important factor, because placenta is now the interface, taking all the mother's nutrients and bringing it to the baby. And the mom should not have any problems such as infection or substance abuse. And we know high altitude can affect with oxygen delivery. I'm sure you covered that in physiology with the oxygen dissociation curves. When you look at what affects fetal growth from the fetal point of view, the fetus has to be healthy. Certain chromosomal abnormalities, the fetus don't grow well. Inborn errors of metabolism or a malformed fetus, or if there is an infection, they don't grow well. But there are also hormonal factors. This is an endocrine lecture, so we will focus on hormonal factors that affect fetal growth. So if you look at the different factors, the most important hormone that regulates fetal growth is insulin. Higher the insulin in the fetus, the larger is the baby. So macrosomia associated with insulin excess, and in insulin deficiency condition, like babies that have neonatal diabetes or whatever reason, if they cannot make insulin or insulin levels are low, those babies tend to be smaller, intrauterine growth retarded. The hormones that play a big role in postnatal growth, such as growth hormone, as its name implies, or thyroid hormones, they are not major players in fetal growth. So when you think of fetal growth, the first thing that you should think of is insulin. And the other important factors are insulin-like growth factors, and I'll come to that shortly. Some studies have shown some association between leptin and placental growth hormone levels, but there is no direct cause and effect relationship with these hormones and fetal size. And as I mentioned, insulin-like growth factor, as its name implies, it works like insulin, and it's an important growth factor in fetal growth. There are two kinds, IGF-1 and IGF-2. There are also specific growth factors for specific tissues. For example, epidermal growth factors involved in development of lung, adrenal, and gastrointestinal tract, transforming growth factor, platelet-derived growth factor, fibroblast growth factor. This affects mostly skeletal growth. In fact, mutations in this receptor has been associated with achondroplasia, or dwarfism as we commonly know it. The nerve growth factor is necessary for nerve growth. So these growth factors are independent factors, as their name implies, are involved in growth of specific tissues or organs. This data set, even though published in 1997, though old, still holds true. You can see here the major players in fetal size are insulin, and here are small for gestational age, appropriate for gestational age, and large for gestational age babies. and the insulin level increase with the size of the baby. And the same relationship you can see with IGF-1. And most importantly, such a relationship does not exist with growth hormone. So even if a baby is born with growth hormone deficiency, they are normal sized babies. You don't expect them to be smaller. Why are we concerned about fetal growth? Because we know now that fetal growth is linked to many adult diseases. And this is the basis of Barker's hypothesis. What they noticed was when people were exposed to famine during World War conditions and mothers were put on rations, they just got 700 calories of daily food. When those babies were born, they were not only smaller, when they tracked them as adults, they became more obese. They had diabetes, they had hypertension, and many other factors. And what is the reasoning behind it? When there is intrauterine deprivation, you change your genetic makeup to conserve energy. You make epigenetic changes, you make genetic changes, learning to live under thrifty conditions. But of course, when the baby is out here, born, they are exposed to adequate or excess nutrition in today's society. So you have the makeup to store energy, and you have McDonald's, and the combination is not good. So these children of those mothers who are exposed to intrauterine, exposed to malnutrition during pregnancy, those babies tend to have many of these diseases as adults. They were more obese, and this cohort has obesity-related diseases like type 2 diabetes, dyslipidemia, hypertension, abnormal kidney development, as well as coronary artery disease. And importantly, from a growth perspective, for a pediatric endocrinologist, 10% of these babies don't ever catch up. They have something similar to growth hormone resistance, that their body does not respond to growth factors or growth hormone, and they don't grow. And we sometimes have to treat them with exogenous growth hormone therapy. So I'm going to shift now from fetal growth to postnatal growth, and we'll spend most of our time focusing on this aspect. As we all know, one of the most rapid phases of growth is infancy. You know, the birth weight triples by 1 year, and the birth length doubles by 2 years. That's phenomenal growth. And if you look at the curve, that's pretty obvious. If you look at postnatal growth, and if you follow the arrow, infancy is a period of very rapid growth. Post-infancy, we grow at a very steady rate during childhood. There are no major spurts, unless if there is any medical problem, of course. Otherwise, people tend to grow on the curve. And then when they hit puberty, they have a growth spurt. So you can divide that into rapid phase of infancy, a childhood growth, and a pubertal growth spurt. So we will look at postnatal growth in 4 different headings. First, we'll look at what are the factors that influence growth. What do we need hormonally or endocrine-wise to grow? And then, if you are the doctor in the clinic, how are you going to evaluate growth? What are the different things that go into assessing a person's growth? How do we monitor growth, and what are the problems, and what can we do about it? So first, we'll talk about the different factors that influence growth. So clearly, like you've heard many times, everyone, we always say in peds endocrine, every child has to be healthy, fed, and loved. You know, forget all the hormones and everything. So they have to be healthy, there should be no underlying diseases, they should have access to good food, and psychosocially loving parents. Those are a must, you know, before we move on to endocrine factors. But one of the most important factors is also genetics. If your parents are very short, it's unlikely you're going to be a 6-footer. If your parents are very tall, if you don't make it to mid-parental target height, we look for abnormalities. So genetics plays a very important role as well. But here, again, being endocrine lecture, we'll focus on the hormonal factors that are involved in postnatal growth. And the most important is the growth hormone and growth hormone at the IGF axis. And we will go into that a bit in detail. The other hormones that are required are thyroid hormones, sex hormones for the growth spurt during puberty, and some growth is also mediated by insulin, like obese people can be taller, exogenous obesity, and you need parathyroid hormones and vitamin D for skeletal growth. But if you look at which is the most important hormone for postnatal growth, it would be growth hormone, with crucial assists from thyroid as well as sex hormones. So where is growth hormone produced? Have you had that lecture already? Okay. So growth hormone is made in the pituitary gland. And once made in the pituitary gland, it circulates in the bloodstream and then reaches target tissues. And the receptor for growth hormone are found in multiple tissues, but one of the most important organ is liver. So you can see here growth hormone, it can bind to the growth hormone receptor in the liver, and it induces production of this factor called insulin-like growth factor 1. It's also called somatomedin. It's a mediator through which growth hormone can act. Growth hormone can have direct effects, but it can also work through IGF-1. This IGF-1 made in the liver circulates in the blood. It is bound to binding proteins. It's a big family of proteins. There are 1 to 6, but the most important is binding protein 3. And this binding makes it more stable, and half-life increases, circulates in the blood till it reaches the target tissues where it can act. And then this is cleaved from the BP3, and the IGF then acts on its target, which is, it can be bone, cartilage, muscle, it can be any tissue. So what regulates the release of growth hormone from the pituitary? In endocrine, it's always a 3-tier system, and hypothalamus has something to say in most hormonal production from pituitary. So this is one of the axes where there is a stimulatory factor as well as an inhibitory factor. And the stimulatory factor is growth hormone releasing hormone, and the inhibitory factor is somatotropin release inhibitory factor. So the net effect, a stimulation or an inhibition, results in production of growth hormone from the pituitary. And once it's released, like we saw in the previous slide, it acts on the liver and other tissues, and then through IGF-1 and BP3 can affect target tissues as well. So what is the action of growth hormone? As its name implies, promote growth. It can act on multiple tissues, muscle, liver, and adipose tissue. But the net effect, you can see, it increases amino acid uptake, protein synthesis, collagen synthesis in the chondrocyte through IGF-1, and the net effect is to increase organ size or organ growth. Growth hormone has direct effects, but growth hormone can also act through IGF-1. When you look at growth, they both act together. The actions of growth hormone are very similar to action of IGF-1, both promote growth. The place where they differ is in carbohydrate metabolism, where growth hormone has an anti-insulin-like effect, whereas somatomedin acts more like insulin in increasing insulin sensitivity. And when you look at the pattern of growth hormone secretion in one day, there are multiple pulses of growth hormone. So you can see here it's not a stable production, there are multiple peaks. A normal person can have 12 peaks in a 24-hour window. So why this understanding this peak or knowing this peak is important? If a child comes to pediatric endocrine clinic and I want to see if they have enough growth hormone, we never draw a random growth hormone because I have no way of knowing whether I'm catching a peak or I'm catching a trough. So it's important as a clinician for you to know random growth hormone does not have any role in knowing whether the person is growth hormone deficient or not. And as you can see here, you make more growth hormone during sleep. Again, you've said if you sleep well, you'll grow well. Have you heard that before? So because your body makes the most growth hormone in the slow wave sleep, in the first phase of slow wave sleep. So you want that physiological surge to happen so your body can grow through the day. And if you look at a lifetime, this is a single day capture. If you look at what happens in the lifetime, you have a peak in growth hormone production during puberty. That's when you're going to have a spurt. I said in infancy you grow a lot. In puberty you grow a lot. Those are the times where you really increase the growth hormone production. And once growth is complete in adult life, the levels of growth hormone comes down. And because growth hormone regulates IGF-1 level, if you look at IGF-1, the levels of IGF-1 too peak during puberty. So during puberty, this spurt of growth hormone release and IGF release favors growth, favors increase in height. But we all know from our experience that we don't all peak at the same time. Each person has their growth spurt at different times, and that, in middle school and high school and late elementary school is pretty obvious. And if you look at gender-wise, there's a huge difference. Girls peak early, but the peak is not as robust as in a male. Males peak later, and I'll show you some slides where you can see that clearly, images of children. And you can see that girls tend to get taller. When you think of middle school, girls are taller than the boys. But the boys peak later, and they have a more robust peak. So the timing of the growth spurt differs. Not only with gender, even among people it differs. And we'll go into that in detail later. So the next hormone, after growth hormone, that's important for postnatal growth is thyroid hormone. Thyroid is also a major contributor of postnatal growth, and I'll show you some examples of that later. And if a person is hypothyroid, that can affect growth in postnatal growth as well as skeletal maturation. So if you look at their bone age, or if you take the x-ray, if the person is 9 and if they're hypothyroid, their bones will be like a 7-year-old or a 6-year-old. So the bone age can be delayed because that's a delay in skeletal maturation. The thyroid hormone has direct effects on epiphyseal cartilage. It promotes growth, but it also makes the body make more growth hormone. So it has a permissive effect on growth hormone secretion. And there is decreased growth hormone secretion in patients who are hypothyroid. That in hypothyroid is missing here. You can add that. That's the only change I had from what I submitted earlier. So in hypothyroid patients, the growth hormone secretion is decreased. So you can have poor skeletal growth in a person who's hypothyroid. So I want to ask you, this is a patient we follow at Children's Hospital at Montefiore. She's now become an adult. I was a fellow when this patient came in from Vietnam. You want to guess how old she was? At this picture, this was the first visit. 5? Any other guesses? Pardon? Older than that? Yeah. She's sitting on her mother's lap. She was 10 years old. And look at, this is where we've plotted her on the height. This is her weight, this was her height, and her height was in the weight portion of the curve, and her weight was here. And remember I said thyroid is necessary for skeletal maturation? And you can see here her bone age. She was 11, but her bones were like a 2-year-old. Profound hypothyroidism. And I'll go back to see her. You can see from her face, right? There are features of cretinism of hypothyroidism. She did very well. As you can see, she almost reached 410 as an adult. 13 years we have followed her. She's now gone on to adult by just replacing her thyroid hormone. This emphasizes how much a role thyroid hormone plays in skeletal growth. So this is another child. Here is a child who was growing along this percentile and then became hypothyroid and the growth deteriorated. And this is a time point where levothyroxine or treatment was started, and you can see rapidly the growth improved. So you can tell thyroid hormone plays an important role in postnatal growth. So what about sex steroids? We all know puberty is the time we get the growth spurt, and puberty is the time our body is making androgens and estrogens, the 2 hormones. Both these hormones contribute to growth. Androgens accelerate bone age maturation. It also increases growth hormone and IGF secretion. So they have a permissive role. So when the sex steroid level goes up, you see the peak in growth hormone secretion during puberty, and that results in increased linear height. Estrogen has specific roles. In addition to increasing cartilaginous growth, it also increases lateral growth of the pelvis for delivery. The body is so beautifully programmed. Like estrogen has differential skeletal effects on the pelvic bone. Their actions are, however, biphasic. In small amounts, they stimulate growth. In very high levels, by the time of end of puberty, you have so much sex steroids, you eventually end up fusing the growth plate. And how does that happen? And before I go to that, I put the slide just to show that this is the growth rate. It's height velocity. You can see as you go into childhood, you're not growing as much as you grew in infancy, and it plateaus a bit, and then you get this growth hormone surge and the pubertal hormone surge, and they both contribute to height spurt that you see around puberty. So what happens in puberty? we know that there is increase in sex steroids, right? And how do these sex steroids, I said that if you have too much sex steroids, you also stop growing after some time. That's because boy or a girl, it doesn't matter, if there is testosterone, ultimately the hormone that fuses the growth plate is estrogen. Boy or girl, the hormone that fuses growth plate is estrogen. Girls make estrogen directly. Boys make testosterone, which is converted by this enzyme called aromatase to estrogen. And net result, that results in epiphyseal fusion, or the growth plate fuses and growth ends. So the hormones that are involved in growth are growth hormone, thyroid hormone, and sex steroids. I'm going to give you an example of an adult male. This case was published in New England Journal. You would expect an adult male to stop growing about 16 to 18, right? But if you follow this growth curve, isn't that abnormal? This adult is a 20, 22-year-old, 24-year-old and is still growing. Generally, you don't grow at that time. So work of this patient showed that the person lacked the enzyme aromatase. So they made testosterone, they were phenotypically male, but because they never converted the testosterone to estrogen, the growth plate never fused. So they kept growing and growing. You know, there comes a time you do not want to be much taller than that. So this person was started on estrogen and the growth plate fused and then he stopped growing. So this highlights the fact that it's ultimately estrogen. Boy or girl, estrogen is what closes the growth plate. And you can see here, this is the person's X-ray before estrogen. The growth plate is still open, whereas here with treatment, the growth plate is fused. And once the growth plate is fused, there is no increase in linear height. What about the other extreme? Can you have conditions where young children make too much of testosterone or too much of estrogen? Are they going to grow too fast and mature their bones too fast? You would think that can happen. And that's exactly what happened. This is again a patient I followed. He was a 7-year-old boy with congenital adrenal hyperplasia. This is a defect in the steroidogenic pathway. Have you covered that already? Okay, so in brief, what happens is in the hormonal, the synthesis of cortisol and adrenal hormone, there's a block in the synthesis. So they are lacking an enzyme. So when there is a block, the precursors accumulate prior to the block, and the pathway they can take anymore is increased androgens that can form estrogen. So these people with CAH will lack cortisol, but will have higher precursors like 17-hydroxyprogesterone that can lead to more androstenedione and testosterone in the pathway. You'll hear more about it later. But the net effect is you're seeing more testosterone and the bones are seeing more estrogen. So when this patient first came to me, he was 7-year-old. And he already had started developing pubic hair and showing signs of puberty. So we knew there was hormonal excess. And he turned out to have a defect in the pathway, adrenal steroidogenesis. But more importantly, for growth perspective, his bones were at the age of 13 and a half. So the bones were much mature. Like you remember in the hypothyroid patient, I showed a 10-year-old who had a bone age of 2. Here I'm showing you a 7-year-old who has a bone age of 13 and a half. What will happen if you don't treat this patient? He'll make more and more testosterone. He will be only 9 years old, but his bones will be 15, 16 done. So they will end up short. He will look very tall. Right now he's at the 75th, 90th percentile. But if you don't treat him, his bones will close. And this is where he'll end up as an adult, not even 5 feet, 4 feet and 4 feet 11. So you really want to keep the hormones in check or in balance. You don't want excess that can accelerate the bones, or you don't want them deficient that the bones cannot mature to promote linear growth. So summarizing what we covered so far, so postnatal growth, the factors are growth hormone, thyroid, and sex steroids. Those are things you should know about. So this is the background physiology. But now you have a child who's coming to your clinic. How do you know, is this kid growing properly? How do you evaluate growth? Evaluation of growth and monitoring of growth is one of the most important things I think we as pediatric endocrinologists do. So to say if somebody is growing or not, you really have to measure them accurately. If they are at the clinic and they're slouching like this and you get a shorter height and next time they come, they stand here, you really have to have a standardized way of measuring height. And it has to be plotted on the growth curve so you can follow how they're doing over a period of time. So you have to measure it accurately, you have to plot it, and you have to track it. 3 important things you have to do about growth. And I'll show you how. And when we look at growth, we not only look at height, we also look at weight, head circumference, we also look at body proportions. And I'll show you some syndromes like Marfan syndrome where the individual can be tall, or Turner syndrome. It's really important to see if they're proportionate or not. For example, achondroplasia, we talked about dwarfism, they can have very short hands. So you really have to be able to look at the child and say, is this child proportionately short or disproportionately short? Is there a skeletal problem or is it an endocrine problem? And you always want to look at puberty in relation to puberty. Because as we said, as you go through puberty, you're going to have a growth spurt. So you can take 2 15-year-old people. One 15-year-old can be going through puberty. That person is clearly going to be looking taller to you. Whereas a 15-year-old who is still 10 or 1, hasn't started puberty, is going to be shorter. But they may end up at the same height because this person may look short now, but still has growth left and the pubertal spurt left. So you can never assess growth without taking puberty into consideration. So this is how we measure height. We have a stadiometer. We make sure there's a standardized way. The kids are not tippy-toeing, especially parents tippy-toe. If you ask them how tall are you, they always tell you 2 inches higher, especially the dads. So, so you want to make sure. We sometimes measure parents too because we do mid-parental target height. If they're tall parents, they're going to have tall kids, so we don't go by the history. So we measure them and we have certain standardized. You want to make them close to the stadiometer. Make sure this, this moving scale is flat, and at the line of sight you take height measurements. And we always take 3 times and we average it because height is such an important thing when you evaluate growth. And once you measure, you have to plot them because the growth charts are very important. They tell you where they fall on the percentile. They're different for boys, they're different for girls. Different syndromes have different charts as well. Different age groups have different charts. 0 to 36 months is a different growth chart because remember they grow very rapidly at that time and you see them more frequently. So you see their growth and you plot their growth carefully on the growth chart, and you can find all these growth charts in these websites, CDC website. And once you get a single measurement, you're seeing the kid one time in the clinic and you have to actually see how they've been growing. So I'm going to give you an example here. So these are 2 individuals. You will see them represented as a blue dot and a brown dot. You can see they superimpose on each other. Like they are in my clinic, all I'm seeing is they're plotting at the 5th percentile, right? But then when we always tell them, bring the growth chart from the pediatrician. So who do you think is abnormal? Who are you more concerned about, the brown or the blue? Blue, right? The brown has always been a short person, probably family is short, but always growing along their own curve. Each one follows their own growth curve. Whereas look at this person in blue, was at the 50th percentile, now at the 5th percentile. Did something happen? Because you can develop hypothyroidism, you can develop a brain tumor, you may not make growth hormone. So it's very important to track the height. A single point should never be used to reassure or get into a costly workup. If you saw this growth chart, you knew who to work up. So this slide again shows the importance of tracking the height, and you can see here this person was here, and at the follow up they started to fall off the growth curve, and when this happens we worry about serious pathology. We worry about brain tumor. We picked up kids who came for short stature to have germinoma in the brain. So they may have no other symptom than growth failure. So you really have to know that short stature is not a disease, but it may be a window through which you can diagnose much more serious problems. Or they may have a simple hypothyroidism and you treat them and they do very well. So when you not only do you measure accurately, you plot it, you track it, and then you know if this person is crossing percentile or not. So not only did you do all the things I mentioned, always look at the individual kid in the context of puberty. Because the same 15-year-old, one may look tall, one may look short, The tall person may have completed puberty, finished growth. So that may be their adult height, whereas the short person has the entire growth spurt left. So you really have to look at it in the context of puberty, and you also have to look at the context of bone age. How much room is there in their bones for them to grow? Go back and think about the 7-year-old who's 13 and a half bone age. That kid didn't have much time left to grow. So you really have to look at the bone age. Yeah?
How do you measure bone age?
Yeah, I'm going to come to that. Yeah. It'll be a couple of slides down here. Okay? So again, to reinforce, there's a gender difference in when you go through puberty. Females go through puberty earlier compared to boys. So what do we use to determine bone age? We use bone x-rays. And for standardization, it is always the left hand and the wrist for any individual to assess bone age. And when we have a big atlas, like no endocrinologist can look at the x-ray like this and say exactly how old the person is. We have an atlas, we turn the pages back and forth, we look at how many carpal bones are here, how mature they are, how are the growth plates here, how are the phalanges looking. So we look at each and every bone and we do a composite of bone age and see if this person at the right bone age, delayed bone age, or advanced bone age. So you can see the difference in bone age in two different people. This is a boy, 8 years old. The bones are much more immature compared to a boy 14 years. Can you appreciate the difference? So we keep the book. We don't just look at it and say, we look at the atlas and we can say how old they are. And there's standard deviation for each bone age as well. And why is it important? And we will go into that a little bit later. But more important to know that puberty is not happening in every girl at 12 years of age and every boy at 14. There are people who go through puberty early. There are people who go through puberty late. So, and chronological age that way can be very misleading. People who go through puberty can grow very fast and fuse the bones. So the tallest 5th grader is not necessarily the tallest 9th grader, because the other kids who are slow are slowly catching up to them. So if you take a cross-section of middle schoolers, you can see almost a 15-centimeter difference between them. So going back, we said about plotting, tracking, taking puberty into account, taking bone age into account, but what about parents' height? As I said, if you have tall parents, you're going to be taller. If you're short parents, unfortunately, that's your genetic potential. You're going to be a little bit taller, maybe because of better nutrition, depending on where your parents grew up. But it's always important to consider parents' height. So when we see a kid for short stature, we always ask mother's height, father's height, we ask grandparents' height. And once we have that, we can calculate what we call the mid-parental target height. So based on the parents, where will this kid land up? In the first 2 years of age, even very short parents can have tall-looking babies and, well-nourished. So sometimes nutrition can drive the growth in the first 2 years. But afterwards, that nutrition effect weans off, and they really start deviating towards their parents' genetic heights. There are different formulas to calculate parental height, and I like this one because it's very easy. You think boys are going to be taller, so you add the parent's height, you add 5 inches, and divide it by 2. And for girls, you add the parent's height, you subtract 5 inches, and divide by 2. So why is this important? As I mentioned earlier, if I see a 5'11" mother, and I see a 6'4" father, and the kid is plotting on the 10th percentile, if they track and grow well, they're not going to make it anywhere near their parents' target height. Then I worry whether this kid has any other problem that we are missing. So you really, if you see a pediatric endocrinologist note, as we track parents' height, we plot also mother and father's height. And we also ask about familial timing of puberty. And why do I say that? Like some families, it just runs in their families. The father started shaving late. These we call constitutional delay or late bloomers. It runs in the family. Say if you have a dad who says, oh, I had my height spurt when I was in college. If you're seeing that boy for short stature, you know the boy probably got that genes from the dad, and he is going to have constitutional delay. Or a mom who says, I attained menarche at 15. That's much later than normal. So you do that tend to run in the family. So that's another important piece of information you want to gather when you're seeing a kid for short stature. So just summarizing what we talked about, when you're evaluating a child's growth, you want to see pattern of growth. Means, is this kid tracking? Is this kid growing steadily? Is this kid changing percentile? What is the height velocity? Like how much did they grow from last time to this time? What is the genetic background of the child? I mean by that, what is the parent's height? And what ages did the parents mature? Like, did they have late puberty in their history or not? And when you look at the child, you just eyeball and see, is the kid looking proportionate? Are the body proportions normal? Are you dealing with any kind of skeletal dysplasia, not an endocrine problem? And where are they in puberty? Has this child started the adolescent growth spurt? So when you see a child, you are taking into account so many factors because they all influence how a person is going to grow. So now you've understood what are the factors that influence growth. How do we monitor growth? Of course, they come to the doctor because they think there's a problem with the growth. So what are the problems associated with growth? Fairly simple. They're here because they're tall or they're short. I have to say, in practice, if I have to give a number out of 100 kids I see, 98 will be for short stature compared to 2 for, even you take growth problems. No one comes to me and say, my kid is too tall, do something. They're so happy they're playing on the basketball team. Really, no one comes to us. Girls, sometimes parents get concerned when they're reaching 6 foot and then they worry and then they come. But otherwise, boys don't come to us for tall stature, they come for other problems. But one of the most common reasons they come to pediatric endocrinology is short stature. So what is short stature? When a child's height is below 2 standard deviation for what is normal for age and gender, it is short stature. And you can see it comes in different flavors. You can be growth hormone deficient. You can just be familial short stature. You may have a syndrome. You can have a skeletal dysplasia, hypo or achondroplasia. So the diagnosis of short stature didn't tell you what was the problem with the patient. It just told you they are short. So it's a symptom. It's not a disease. So as a physician seeing somebody, you want to find out, is anything wrong with this patient? And if so, what is wrong? And why did I say, is anything wrong with the patient? You have a question?
Do they have different charts for different cultures, different countries, or different?
Yeah, very, very good question. You know, the initial growth charts were made from a Midwestern population, for the Midwestern white American population. So when you plot an Asian kid on that, it is a problem. They always look like they're tracking at the 5th or below the 5th. But they've been modified. You know, they've included children of more different ethnicities since the first time the growth charts were formed. So now they are much better than they were years ago. Yes, it's an overall, and there are ethnic differences. And we always tell, you know, when an Indian kid comes and they're petite and parents are petite, or an Asian kid petite, we always tell them, you know, this is a guideline. And we go with your parents' height and everything is. So when they come to us, the first step as a pediatric endocrinologist, we're thinking, is it normal growth pattern or is it a problem medically we have to diagnose? And why am I saying that? Because 90% of the kids who come to us are just variations of normal. We just assess them more comprehensively than just looking at them and saying they're short or plotting them on a curve. We do pubertal assessment, we look at the bone age. We are often able to reassure them and say, look, he hasn't started puberty or she hasn't. The best is yet to come. The height spurt's going to come. This is what we predict based on the bone age. So most times we just reassure them. But you have to reassure, you have to know what is variation of normal. And that is majority of who you see in practice. So we'll first talk about what are the variations of normal, and then we will go to when do we think there's a problem with the child. So this is, I took the picture of the internet, so I blanked all the faces, but this is a 6th grade class picture. You can see this tall kid, this short kid, a girl short, like, you know, at that age, it's very hard to just look at them and guess an age or what grade they are in. You know, all of you have had that experience. I have a son in high school, so you see that the girls who are friends with them are much taller and they look much older than them. So the two variations of normal are familial short stature and what we call constitutional delay. And I'm going to go over each of them because I think whatever field of medicine you go to practice, you will have so many friends, relatives, family talking to you about height and short stature. So you have to be able to tell them what is normal and what is abnormal. So when do we call it a familial short stature? So this is a curve of a person who is short, not very tall, below the -2 SD, but is always growing in their own curve. Because if you have a growth problem, you're going to cross percentile. This person's not doing that. They're just growing normally. And this is how a curve would look in familial short stature. These people have family history, means parents or grandparents are short, and their normal birth weight, there's no neonatal history that you need to worry about. They're short when you plot them on the growth curve, but they always grow well. They grow parallel to the curve, they have their own growth curve. And when you look at the bone age, that is equal to chronological age, means their bones are maturing the same way as their body is maturing. So there is really no reason the bone is either delayed or advanced in these children. And their puberty starts at the normal age. So in these kids, you really can't do much. They're born with their genetic potential, and we really don't try to intervene. We just reassure them that everything looks normal. You know, we may get a bone age, we look at them, and they will go through puberty normally. And so this is another thing where a growth curve tells you whether they are familial short stature. The other variant of growth is what we call the constitutional delay. You may have heard late bloomers, like, you know, kids who don't hit puberty till they start high school or midway through high school. That's again a variation of puberty, but it's not abnormal because they eventually catch up. So this is how their growth will look. So this is a familial short stature kid. These are cartoons. These are not actual patients. But you can see a constitutional delay kid. Looks like they are crossing percentile, but when you look at them, they have nothing wrong with them. When you look at their bone age, it's not equal to the chronological age. It's a little bit delayed. But when they start their height spurt, they catch up and they do well, and they reach where they're supposed to reach. So these are the late bloomers who just wait to have their height spurt later. But they reach their final height, predicted based on the parents' height. So when you look at these children, they are healthy. They are just not, they are completely normal. They just don't start puberty with the rest of the group. There is no history of malnutrition. They are well nourished. They have no medical problems. They have a family history. The father or mother will tell you, oh yeah, this happened to me too. I had my height spurt in high school, late senior year, or I had my height spurt in first year of college. A mom will tell you, I had menarche late. So that gives you a clue that this late blooming runs in their family. When you look at them, they look normal. Their physical exam is normal. Their body is proportionate. There's no skeletal dysplasia. They may be below the curve, height below or at the -2 SD, but they're growing. They're not completely flattening out. They have a minimal growth rate of 3.5 centimeter per year that tells you that they have everything they need to grow. But their puberty is delayed. That is the key differentiating factor between these people and familial short stature. The delay in puberty, and along with that, a delay in bone age. So if you see a 14-year-old, parents come all the time. They're concerned because the kid wants to play baseball, basketball, but they are short. And then they come to us, we examine them. They're not in puberty, they're 10 or 1. We get an x-ray, if the bone age is 12. We can reassure them and say, you know, his bones are a little late. He will catch up. He'll eventually get the height, but he will get there. So we will make sure they don't have any medical problem. We will check to make sure their thyroids, everything is normal. Then we don't do random growth hormone levels for the reason I mentioned. Do you recall that growth hormone goes up and down in the body? You cannot just draw a random level. We do IGF-1. We look at the blood tests, make sure they're normal, and then reassure the family the height spurt is coming, but it's just a little late. So once you have taken care of 90% of your patients fall into one of the variants, familial short stature, constitutional delay. But our job as physician is to make sure you're not missing any medical reason. Are there any pathological causes for short stature? And they can be varied. There can be syndromic causes of short stature, and I will just touch briefly about Turner's in the next few slides. And they may have problem with nutrition or other medical condition. A kid with renal failure is not going to grow so well. A kid with IBD or cystic fibrosis may not grow so well. So there are many reasons why a kid can be short. We just want to make sure that we've ruled out all of the diseases that can contribute to short stature. And then make sure they're not on medications. Sometimes children are on high-dose steroids or glucocorticoid for nephrotic syndrome or something. That can actually reduce IGF secretion or growth hormone secretion and prevent growth from happening. So you want to make sure the kid does not have any medical problems. That's part of your job too as a doctor. So one of the common, not the most common, but not as uncommon is Turner syndrome. And these children, 100%, all Turner girls are short. So they come to the endocrinologist, and that's when the diagnosis is made of Turner syndrome. And if you look at these girls with Turner syndrome, I put some pictures from the web, you can see they look relatively like any child you may see in everyday life. So as a clinician or as an endocrinologist, you should really have a high index of suspicion. You should look for other features of Turner syndrome. You know, webbed neck, cubitus valgus, white space nipple, lymphedema as a child. There are many things you look for. Multiple nevi, Madelung deformity. But once you think or you're not sure whether the kid may have Turner's, we always get chromosomes to make sure they're not 45XO or a mosaic Turner. It's not that uncommon. It's 1 in 2,500 live female birth. And the person who most often makes the diagnosis is an endocrinologist because they come for short stature. They also have delayed puberty because streak ovaries or premature ovarian failure is a feature of Turner syndrome. So what are the endocrine causes of short stature? If we go back to the same 3-4 hormones that we know about, when the body does not make growth hormone, like in growth hormone deficiency, there is not enough thyroid hormone, hypothyroidism, steroid excess because the patient has Cushing's, endogenous or medication with steroids, or they have poor nutrition indirectly to poorly controlled diabetes mellitus or diabetes insipidus, or nutritional deficiencies of such as hypophosphatemic rickets, where the skeletal growth is compromised. So there are many endocrine causes of short stature. So what are the different reasons why a person can be growth hormone deficient? So I want to take you back to the slide we talked about. Remember the 3-tier. Hypothalamus has to be functioning, the pituitary has to be functioning, and IGF has to be made, and IGF has to act along with growth hormone. So you can have problems at many levels. So I'll give you just few examples. You may have a problem with growth hormone releasing hormone being made because that's necessary for the hypothalamus to tell the pituitary make growth hormone. Or you may make the protein, but the receptor for it may be a problem. And there are a group of people who have been shown in Brazil, Itabaianinha dwarfs, and you can see an adult and a similar age adult right next to them, how short they look. Because they make growth hormone, releasing hormone, but their receptor has a problem. So the pituitary never sees the stimulus. You can of course have tumors, other medical diseases, inflammation, scar tissue that can also damage the hypothalamus. Sometimes you can, the pituitary may be the site of the problem. The person may not be able to make growth hormone deficiency, growth hormone. So that leads to growth hormone deficiency. Or the person makes growth hormone, but the growth hormone cannot act because the receptor for growth hormone has a problem. And that has been shown in a group of people, and they are called the Laurence dwarfs. And these are age-matched children who are normal, and you can see the kids with Laurence syndrome, how short they are compared to them. These are 13 and 8-year-olds. And look how, because they make growth hormone, but they cannot act because the receptor has a problem. Or they may have a problem making IGF, which is necessary for growth, which is a growth factor. Or they may have a problem with IGF action. So you can have, so many things can go wrong in the system from hypothalamus to the tissue level. And growth hormone deficiency is not uncommon. It's 1 in 4,000 children, or 1% of the short kids we see. And it could be because of congenital problems. It could be because of tumors like germinoma. inflammation or sometime post radiotherapy or chemotherapy, the area of the brain is affected and they cannot make growth hormone, pituitary hormones. They all have a classic phenotype and we don't quite understand some of the reasons why. You can see here, I don't know how clearly you can see, they have a little bit of frontal bossing in all of them, a depressed nasal bridge. They have hypoplasia of this cheekbones. They have truncal obesity because growth hormone breaks down fat and these people don't have that action of growth hormone. And because growth hormone makes the liver make IGF and BP3, if growth hormone cannot act, they have low IGF-1 and low IGF-BP3. So they will have high growth hormone circulating in their blood, but low IGF-1 and low BP3. That tells you they make growth hormone, but the growth hormone cannot act. So how do you evaluate a person with short stature? This is pretty much most of what we had talked about all along. So if I go a little fast, you feel I'm going a little fast, please feel free to stop me. The most important thing is history. And we talked about all the different things you want to cover when you see a kid with short stature. The next important step is physical exam. You want to make sure they're proportionate, not proportionate, pubertal staging. When you say radiographic, that includes bone age. You want to see where they are. Sometimes you may need to image the brain to see they don't have a tumor, like an MRI. And of course, lab tests to make sure they're making enough IGF-1, they don't have any chronic disease, and their thyroid functions are okay. So these are the kind of screening labs we do in somebody who looks shorter than their genetic potential. There are specific histories we ask for in evaluation of a child with short stature. One of them is micropenis or microphallus. Growth hormone intrauterine is necessary for phallus growth. So we sometimes see hypopituitarism kids or kids who have growth hormone deficiency can have, if they had it intrauterine, can have a micropenis, a small size penis. We also look for hypoglycemia, but remember we talked about how growth hormone plays a role in carbohydrate metabolism, and it breaks down fat and gives nutrition when a person is fasting. So if you don't have that, they may have history of hypoglycemia. Growth hormone, thyroid hormone, all of them have a role in making of bilirubin and exporting out of the liver. So you may have a history of prolonged neonatal jaundice in these patients. And because pituitary gland is in the midline, defects in pituitary are associated with other midline defects. We always look for cleft lip, cleft palate. We ask for history of brain tumor, radiotherapy, family history of genetic syndrome. So a lot goes into the history of a kid with short stature and initial evaluation. Does anyone want to take a guess what this is? So there's one central incisor, right, instead of two incisors. That's a feature, a midline defect that can be associated with hypopituitarism. I have a patient who was born, who had one single central incisor and then was hypopituitarism when we followed him. So these are the kind of midline defect clues you look for when you examine a patient. You're also looking to make sure you're not missing Turner syndrome, you're not missing Noonan's, hypochondroplasia, achondroplasia, evaluating for thyroid, you're checking for puberty, you're checking for skeletal malformations. The initial lab evaluation, as we talked about, you make sure they're healthy. They may have undiagnosed renal tubular acidosis when they come to us. They come with failure to thrive. We diagnose them with Barter's, Gitelman, different syndromes where they have electrolyte imbalance, polyuria, and so you're an endocrinologist, but you're trying to make sure that there's nothing else wrong with them. So you do a broad screen. We, in fact, catch a lot of celiac kids these days. Kids with celiac disease, they present with short stature in the absence of any other signs or symptoms. They don't have the characteristic abdominal pain or intolerance to gluten. They never come with the classic history. Like when I eat bread, I get stomach pain. We actually screen them, and when you eliminate gluten from their diet, they grow very well. So this is part of the screen we do, and in girls we do karyotype not to miss any Turner syndrome. Random growth hormone, as I mentioned, is not useful, so we look at IGF-1 and BP3, we look at thyroid function tests. If we need to, we can stimulate the body to make growth hormone and see and try to catch a peak. But for sake of time, I won't go into that. But there are different ways to stimulate it. If you make a person hungry, exercise, you make them sleep, or you give them medications, or you change the somatostatin or GHRH ratio in the hypothalamus. You can give amino acid like arginine that actually inhibits the inhibitor. So then the body will make more growth hormone. So we have different ways of trying to catch a peak. And you know, these tests require 3 hours. The patient has to be in the same day. And we do multiple blood draws trying to catch a peak. So that's only if we suspect growth hormone deficiency. And as I mentioned, we look at X-rays to look at bone age. And if we think there may be brain tumor or some other disease, we get a head CT or an MRI. This is an example I put. You may see this in other slides as well. This kid ended up with a diagnosis of histiocytosis, where there's inflammation of the infundibulous stalk. So you can see this is much thicker. So that prevented the hypothalamic factors from reaching the pituitary. So the person presented with deficiency of growth hormone and other pituitary hormones. So how do you treat short stature? That can be a 4-hour discussion on its own. But suffice to say that it's based on etiology. If they are normal, you're not going to treat. If they are growth hormone deficient, you can actually treat them with growth hormone. If they are thyroid deficient, you can treat them with thyroid hormone. Or if for any reason, if their puberty is advanced, then you can actually temporarily hold puberty with this agent called GnRH. And I think I'll be talking to the same group about puberty, and that time we'll go over this in detail. So there are many reasons a person may be treated with growth hormone. These are the approved indications for treatment. And you have it in the slide. You can take a look. And the devices come as a simple, you can see the syringe is very small, like insulin. The needle is very small as well. So even though it's a daily injection, you cannot give it by mouth. The stomach acids would chew it down. So it's a protein. You have to give it as injection. So these children are taking everyday injections. And the needle is pretty small. You can see the tip is very small. And we have some devices on how to check whether they give the growth hormone every day or not. So this is a child with deficiency. You can see how low on the growth curve they were. And this is just an example. And this is the parent's height. This is how we plot them. The kid was much shorter than the parents, but with treatment with growth hormone, see how beautifully they start growing towards the growth curve where they should be. There are side effects of growth hormone treatment. Most of it are associated with rapid growth, like leg pain, knee pain, and sometimes there can be cartilage slipping, like SCFE. And as we talked about, it can antagonize insulin action. So you can have high insulin levels and diabetes, though we've never seen a frank case of diabetes. If there is a tumor or an active malignancy, you don't want to give a growth factor because the tumor would grow. So this is a real contraindication for the use of growth hormone in children. So what about tall stature? As I mentioned, that really forms a very small part of our practice. But again, just like in the variants of normal and short stature, there can be variants of normal. The familial and constitutional short stature are almost one and the same. They're genetically tall parents, so they're genetically tall kids. But you also want to make sure there are no other syndromes. There are certain syndromes that cause overgrowth and height. And I'm told that you will cover some of them in genetics. Here I will show you example. You can see here the parents are very tall. So the fact that these two girls are so tall on the 98th percentile is nothing, this is normal for them. So this is an example of familial or constitutional tall stature. And these are pictures of two kids, one with Marfan syndrome and one with Klinefelter syndrome. They may be tall, but they have so many other manifestations that give you the diagnosis of Marfan's or Klinefelter's. But focusing on the endocrine aspects, I have seen in my 13 years, I've seen two kids who had a tumor in the pituitary. They made too much growth hormone, so they were very tall. So you should always look for growth hormone excess. That is called the pituitary gigantism, because they still have growth plates open, so they only come as tall stature. They're not going to have the features of acromegaly. When you have early puberty, you may look tall, but later you will even out or end up shorter, but it's one of the reasons you have to look at puberty. And the New England Journal article I showed about aromatase deficiency, because you never fuse your bones, you are not going to form estrogen. So these are the endocrine reasons where a person can be tall. Thyrotoxicosis. Or infants of diabetic mothers may be very big because they saw too much insulin in utero. Or if they have a genetic defect and they make too much insulin, they can look taller because they are nutritionally, insulin is driving their growth. So there are many reasons, but they are very rare. I have to tell you, all of these are thyrotoxicosis is common, but the others are quite rare. Hypogonadism is fairly common compared to the others. So when we see a child with tall stature, we look to see whether they look syndromic. If they look abnormal, you look for features of specific syndromes. But if they look normal, the first thing you look at the parents. If they are tall and the kids are tall, and if the height is acceptable, we don't do anything. But if the kid is growing too fast, not the final height, but an 8-year-old who's looking like a 12-year-old, we definitely look to see if they are in puberty. And if there is, then we have ways to control the puberty. Then we look to see whether they are making either growth hormone in excess or thyroid hormone in excess. And treatment would depend on what we find, either antithyroid drugs or removal of a tumor. It all depends on the etiology. So the treatment of tall stature, just like short stature, depends on the etiology, but you can always give estrogen to make the growth plates fuse so that they don't, when you treat the etiology, it may take longer. When you give estrogen over 3 to 6 months, the growth plates can fuse rapidly. So, you can use estrogen as a tool to fuse growth plates. I think that is the last slide. I'm going to end here. Thank you very much for your attention. If you have any questions, I'm here.